All right, a pleasant good afternoon, everyone. We're going to pick up where we left off. Today, we're going to be doing complications of aneurysmal subarachnoid hemorrhage. Very noteworthy and, a lot of salient points that we could implement into practice. So, well, you guys know we've gone through the anatomy, anterior posterior circulation. We've done aneurysmal SAH. So now it's just to tap into the complications and then we'll proceed henceforth. So, as it pertains to the complications of aneurysmal subarachnoids, there's several of them. Of course, some are a little bit more important because they pop up a little bit more frequently, but they range from rebleeding, vasospasms, and what we term delayed cerebral ischemia, elevated intracranial pressure, and then plus or minus, hydrocephalus, hyponatremia, and importantly, seizures, as well as some other finer complications that we're going to touch on. Now, rebleeding in particular, I mean, if you look at the literature, it tells you, I mean, about 3,000 North Americans die each year from rebleeding of ruptured cerebral aneurysms, right? And there's certain risk factors associated with it in terms of female gender, high-grade SAH, large aneurysms, and that systolic blood pressure, once it gets over 175, puts them in a higher category of rebleeding. Of course, like I would have explained with elevated intracranial pressures, you can have hydrocephalus developing because precipitously actually because you have obstruction of the CSF flow, right? Could be by blood clot. And of course, also you could have it's also just being blocked because of the blood breakdown products and the arachnoid granulations. Vasospasms, big, 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 huge topic that we should really know because we need to be alert in terms of recognizing this in our patients. I mean, the concept of vasospasms really originated back in 1951. And, we'll see that there's different definitions in terms of clinical and radiographic definitions. And like I said, hyponatremia is particularly important. You see it in 10 to 30% of post-aneurysmal subarachnoid hemorrhages, seizures, and know we would have delved into this a little bit in the last class, meaning that the incidence really varies, and they've been looking at observational studies. But I mean, one literature report by Klassen et al. Back in 2004, so for the past 20 years, really show that you have up to 4 to 26% of subarachnoid patients having new onset of seizures, right? And then we'll delve into the little bit of other things after. So, like I was talking about rebleeding, what we need to understand is that for untreated ruptured aneurysms, the maximal frequency of rebleeding is in the first day, right? And that's up between 4 and 13%. 13.6% of patients will rebleed within the first day, with more than a third of rebleeds then occurring within 3 hours and half of them within 6 hours of symptoms. You see how crucial it is as we talk about rebleeding. After that first day, the subsequent risk is about 1.5% daily for 13 days, right? And this is well established in the literature. And beyond 40, oh, sorry, within that 14-day period, right, 15 to 20% of them will rebleed. After that, 50% will rebleed within 6 months. And really, after that, the risk drops to about 3% a year. And of course, mortality rate is about 2% per year. So, there is a risk. All of that statistics basically just shows us that there's a risk of rebleeding during any period that the aneurysm is left untreated. So, as such as we know, early treatment of the ruptured aneurysm can therefore reduce the risk of rebleeding. And this has been proven in several studies. The other factors associated with rebleeding, in addition to what I told you, of course, is a higher Hess grade, large aneurysm size, and of course, poorly controlled blood pressure, rather. So, what do we do? I mean, like I said, the optimal method of preventing it is early coiling or surgical clipping. They've seen that bed rest and hypodynamic therapy, which is a concept we'll discuss at length in a little bit, it does not prevent rebleeding. So, we really need to get in there and coil or surgically clip these aneurysms, right? Now, something that I wanted to expand on, and we did mention it before, is the role of antifibrinolytic therapy because it's popped up where, do we use tranexamic acid? Do we use aminocaproic acid? And the summary in terms of a practice guideline is that the role of clot lysis in early rebleeding is uncertain, right? So, as I would have mentioned before, they would have said that in essence, if you have an unavoidable delay in treatment of the aneurysm, right, and there's a significant risk of rebleeding and you have no medical contraindications, up to 72 hours, you can pursue tranexamic acid or aminocaproic acid, right? But outside of that, there really is no role for it. And that's a practice guideline. And I just wanted to highlight this study, the Ultra study, just for us to be aware, which is where they basically compared. It was a multi-center prospective study, right? And it was randomized control. And what they did is that they looked in 8 treatment centers and 16 referral hospitals. And this was done in the Netherlands, where they looked at adding tranexamic acid to care. And of course, just control not doing it, right? They immediately did the 1 gram bolus at first, and then they continued every 8 hours. And their primary outcome was really to see, well, did it improve clinical outcomes? And what they found in the Ultra study is that no, in patients with CT-proven subarachnoids, presumably caused by a ruptured aneurysm, doing this did not improve the clinical outcome at 6 months, right? So just be aware of, the literature and the data that's out there. So the next big concept is vasospasms, right? And vasospasms are most commonly seen following some cases of aneurysmal subarachnoid hemorrhages. You can also see it after other intracranial hemorrhages and head trauma, right? It's not just after subarachnoids. Ideally, there are two, but not necessarily reconcilable definitions in that you have clinical vasospasms and you have radiographic vasospasms, right? And radiographic vasospasms is really identified in between 20 to even 100% of arteriograms performed during the 7th day following a subarachnoid hemorrhage, whereas clinical vasospasms associated with radiographic evidence is only seen in up to 30% of patients, right? So in keeping with vasospasms, there's really been a shift away from the thinking of the deleterious effects of subarachnoids in terms of vasospasms alone, as in a vacuum. And now we have the concepts of delayed cerebral ischemia and early brain injury coming into play. And delayed cerebral ischemia in particular, it has a set definition. It says it is defined as having delayed development of a neurological deficit, a decline in Glasgow Coma scale of at least 2 points, and or cerebral infarction unrelated to the aneurysm treatment or other causes, right? And it's really an umbrella term that's then going to encompass several other clinical entities, which would be the vasospasms that we just spoke about, delayed ischemic neurological deficits, as well as asymptomatic delayed cerebral infarction. And in addition to that term, like I was telling you, is the concept of early brain injury that in addition to direct mechanical damage from that subarachnoid hemorrhage, you also have early brain injury being linked to, that transient increase in your intracranial pressure, reduction of cerebral blood flow, apoptosis, as well as your cerebral edema that you're going to have. And the infarctions that you tend to see in delayed cerebral ischemia, they're generally two common patterns, and that's your cortical infarcts, which can be single, so it's like a single cortical infarct, which you see in up to 40% of patients. And then you have multifocal infarcts, right? Which is usually often distal to the ruptured aneurysm itself. What I want us to understand is the presence of a delayed cerebral ischemic related infarction is a poor prognostic sign by itself. It's actually associated with a fivefold increase in terms of the odds of an unfavorable outcome at 1 year, right? The other things that are associated with the ischemia is in particular, if you have involvement of ischemia of your middle cerebral artery territory or your anterior cerebral artery territory, that's also particularly associated with a poor prognosis, right? And this was confirmed even in most recent studies. For instance, there was one in by Veldeman et al. In 2024, which is this year, and they've confirmed this as well. So clinical vasospasms, the diagnosis is one of exclusion, and really sometimes it cannot be made with certainty. And by exclusion, what we're going to say is that You have to rule out all the other causes before you figure that, well, okay, you know what, this is indeed you're chalking it up to clinical vasospasms. And it's characterized by confusion, a decreased level of consciousness. Sometimes you have a focal neurological deficit, and the thing with it is that it ranges from mild reversible dysfunction to permanent deficits, right? And it actually carries a fatality of up to 7%. So vasospasm is a significant cause of morbidity and mortality in patients surviving a subarachnoid long enough to reach our care, right? So it's not only the direct effects of aneurysmal rupture and rebleeding, but having vasospasms on top of that is associated with greater deficits in this subset of population, right? So that's the clinical vasospasms that we're talking about. And as the name suggests, that was clinical. Now, radiographic is we're talking about the evidence on radiography, right? The incidence of angiographic vasospasms following a subarachnoid hemorrhage is around 50%. And what it is really is that you see arterial narrowing demonstrated on cerebral angiography, often with slowing of the contrast filling. It doesn't necessarily mean that if you see a radiographic vasospasm, the patient, I mean, this is one of the cases where they actually say clinically correlates, because it doesn't actually mean that you're going to have a clinical vasospasm if you see it on CT, right? And the diagnosis is solidified by previous or subsequent angiograms showing the same vessel. So in essence, we're looking at it before, we're looking at this one, and we're looking at any scans after to see um, if indeed, the change in the caliber of the vessels, right? Um, yeah. So timing of these clinical vasospasms now, the onset, which is important, usually you generally don't see it before day 3, but the maximal frequency of onset is usually between day 6 and 8. And there's a typical what we call at-risk period, which is between day 3 and day 14, right? Clinical vasospasms is thought to almost always resolve by day 12, but radiographic vasospasms tend to take a little while longer. It can last up to a month even. Now, the onset is usually insidious, but about 10% of cases can have an abrupt and severe deterioration. So, characteristics. Clinical vasospasm, like we were saying, we understand they'll be confused, they'll probably have a focal neurological deficit. So generally, these are the patients that they can have non-specific or non-localizing findings, such as new or increased headaches, alterations in the consciousness, a little bit disoriented, a little neck pain. They can also have cranial nerve palsies and focal motor deficits, right? And in some cases, they have symptoms that are going to fall into syndromes, right? Particularly the ACA and the MCA. And one of the things I want you to remember is the vasospasm incidence is actually high in the distribution of the anterior cerebral artery versus that of the MCA, okay? And remember, this is clinical, but radiographically, what does it appear as? It appears as a relatively long segment of narrowing, and you have tapering towards the end in essence, right? Radiographically. So, like I said, the ACA and the MCA syndrome, because these are the ones that tend to be affected. If the patient ends up with an ACA syndrome because of vasospasms, frontal lobe findings are going to predominate. So these are the patient, they have diminished motivation to do anything. You always have to arouse them. They're drowsy. They're just frontal lobe dysfunction in essence, right? They can have a little bit of urinary incontinence. And what they found is bilateral anterior cerebral artery distribution infarcts are usually due to vasospasms following particularly an ACOM aneurysm rupture, all right? Middle cerebral artery syndrome, hemiparesis, and you can see the distribution as we're talking about, monoparesis or aphasia. These are the ones that they lose the ability to perform, skill sequential task. They can even have a little bit of sensory apraxia as well, right? Now, so we're talking about all these vasospasms, but it's important to understand a little bit as to the mechanisms behind it. And I mean, the truth is the pathogenesis is still poorly understood, but still, in order to treat it and to understand how we're managing it, we should kind of understand, well, how does it originate? So what we do know, it's a chronic condition with long-term changes in the morphology of the involved vessels. So it's not just that you're having is not just that you're having these changes in the size of the and the caliber of the vessel, what you're actually having is contraction. That's what's causing these changes of the smooth muscle in the media of the vessel wall, all right? And that is either because of two things. It's either you have impaired vasodilatory mediators or you have overactive vasoconstrictors. And it makes sense, right? So in essence, if you're overactive vasoconstrictors, you're narrowing. And if you can't dilate, you're narrowing as well, right? And they've also thought that vasoactive substances, neuronal mechanisms, these all play a role in the contraction of the smooth muscle wall. They actually found also that in terms of the blood itself, it contributes to vasospasm, meaning that the oxyhemoglobin component in its pure form actually causes contraction of cerebral arteries, right? When it gets in contact with the vessel. And also, hemoglobin is a powerful scavenger of nitric oxide. And if you remember well, nitric oxide is a vasodilator. If you scavenge up all your vasodilatory effects, what do you think going to happen? Vasoconstriction, right? As well as, once you have injury, and this is at the endothelial level, you have platelet-derived growth factor coming into play. Once that comes into play, it leads to proliferative vasculopathy because now you're going to have vascular stiffening, right? And an impaired ability to dilate again. So you understand where this is going. You also have neuronal mechanisms, like I said, which lead to increase in your vasoconstricted tone, endothelial-derived relaxant factor. If you have an impairment in that, again, vascular endothelium it has a very critical role in vasodilatation, right? So if you have an impairment in your EDRF, you're going to end up with vasoconstriction, as well as you have, just the idea of an inflammatory process and a mechanical process where just by compression, by that blood clots and platelet aggregation can lead to vasospasms. Now, there's like several statements or several findings that they found that has correlated with vasospasms, and I just thought it's important that we recognize them. So the risk is higher where arterial blood is at high pressure conducting the vessels at the base of the brain. Blood clots are especially spasmogenic, which I just explained because of the oxyhemoglobin. There's method to the madness when in direct contact with the proximal 9 centimeter of the ACA and the MC. Now, importantly, not all patients with SAH is going to develop a vasospasm because vasospasms can follow other insults, meningitis, just post-op mass resection. They've actually found correlation with, overconsumption of black licorice, for instance. There's a higher incidence with increasing age of patient, and a history of active cigarette smoking is an independent risk factor for vasospasms, as well as, of course, pre-existing hypertension. But the two critical ones I want us to take away, if you don't remember anything else about these findings, would be the Hunt and Hess grade on admission correlates with the risk. The higher the Hunt and Hess grade, the higher the risk of CVS. And the amount of blood, which would be the modified Fisher grade that we spoke of last week, correlates with the severity of CVS as well, right? And this table was just to remind us, Hunt and Hess, in essence, if you're a grade 5, you have a 74% chance or risk of clinical vasospasms based on Hunt and Hess. And again, you see the more blood that you have, take SAH, for instance, let's say a grade 3, you have a 33% chance of a symptomatic vasospasm, right? But we need to recognize also that there's less utility in these scales per se, because now you have the availability of non-invasive monitoring for vasospasms, like your transcranial Doppler, which we're going to talk about. So, this is a nice guide, but, we're kind of moving away a little bit from it. In continuing with the correlated findings, for patients undergoing early surgery, basically, if there's little subarachnoid hemorrhage left on a CT done 24 hours post-op, there's little risk of vasospasm. And that follows naturally with what we've been saying. You have a lot of blood affecting the brain, then yeah, you have vasospasm. You get rid of it and you have a lower risk, right? So there's a good but not a perfect correlation between the site of major blood clots on CT and the focality of delayed ischemic neurological deficits and visualization in terms of the arteries, right? Hypovolemia, as we know, which is why we always aim for euvolemia. And of course, angiographic dye can exacerbate these spasms. And again, that's because they think, it interferes with nitric oxide production and it's a direct irritant and it can exacerbate vasospasms. Okay, so we know how to look for it. We know how it presents. How do we actually diagnose this? Like I said, delayed onset or persisting neurological deficit. The onset is anywhere between 4 and 20 days after your hemorrhage. The deficit is appropriate to the involved arteries. You have ancillary tests as well. And importantly, you need to rule out other causes of deterioration, right? So other causes, rebleeding, hydrocephalus, cerebral edema, seizures, metabolic disturbances, particularly hyponatremia, hypoxia, sepsis. You need to make sure that this patient has none of these things, or your index of suspicion is low, or you actually have objective evidence. You did a CT scan and you see the Evans index is fine, and this patient doesn't have a hydrocephalus that you need to be concerned about. Patient has it, you repeat it, you repeat your blood works, the patient isn't septic, the patient is doing well on ABG. You need to be absolutely sure that, hey, I've covered all of my bases. His sodium is 138. It's perfect. Okay, well, then I can chalk this up to vasospasm, right? And the ancillary test is where this comes in handy in terms of you can use your transcranial Doppler, CT angiography, MRA, EEG, and look at your alterations in your cerebral blood flow. So CTA in itself, and we'll talk about the Doppler in a little bit, but just CTA in itself, it's specific for vasospasms, but it can overestimate the degree of stenosis. Again, MRAs are used in terms of management. EEG, what you actually see, you have different waves in terms of your EEG, and what you see on the EEG is you see a decline of the percent of the alpha activity, right? So the alpha waves is what you generally see when you're relaxed and the brain is in a relaxed awake state. And what you actually see on the EEG to help with vasospasms is that you see a decline of the percentage of alpha activity, which is called relative alpha. So it basically drops from about 0.45 to 0.17, right? And that decline of EEG power is thought to be 91% sensitive in terms of predicting vasospasms, right? So the transcranial Doppler, like I said, that we're moving towards, is a non-invasive method of semi-quantitatively measuring that velocity of blood flow in a specific artery through the skull, utilizing ultrasound phase shift. And in essence, what happens is that that narrowing of the arterial lumen as it occurs in vasospasm, it elevates the blood flow velocity, and that's detected by your Doppler, right? And these Doppler changes can actually precede clinical symptoms up to 48 hours. So it's actually thought to be part of your routine management that you should perform this transcranial Doppler at least 3 times a week if it's available in your institutions. And daily increases of more than 50 centimeter per second is suggestive of vasospasm, right? And you tend to use the MCA because there's less correlation between these velocities in the ACA and vasospasm, right? And it's important that we distinguish vasospasms from hyperemia, right? Because both can actually increase your blood flow velocities in the MCA and the ICA. And that's why we have what is called the Lindegard ratio, which I would show you in the coming up slides. But the point is, once these values become elevated, understand also that it takes several weeks to go down, right? So here we're talking about the fact that if that mean MCA velocity is less than 120, we interpret that as normal, and then we start to go up in increments of 50, like I tell you, and 120 to 200, we're on shaky territory, and that Lindegard ratio is 3 to 6, and it's suggestive of mild vasospasms, right, with a 60% sensitivity. And once we hit over 200, then certainly, and a Lindegard ratio of 6, severe vasospasms, all right? And this is a table comparing CTA and your transcranial Doppler in terms of what is better to predict, or right, the various tests for cerebral vasospasm. And we see, like I was telling you, the MCA carries a positive predictive value of between 83 to 100%, right, versus your ACA 41 to 100%. And comparing this with CTA for 43 to 100%, we could see why, the transcranial Doppler is useful. So how do we prevent it? Because we know how it presents, we know what to look for, we know how to find it. Well, what do we do to stop it? Really, there's no effective prophylactic intervention for vasospasms. It's been thought that it can be mitigated by preventing hypovolemia and anemia. So we always need to make sure we achieve euvolemia and plus or minus blood transfusion if necessary. But even early aneurysm treatment, it doesn't prevent it. In fact, it just helps to facilitate treating it by eliminating the risk of rebleeding. And surgical removal of the clot can actually reduce the incidence of it, right? But to say stop it, no. All right, so we've gone here. treatment. What do we do with it? So there's several modalities that we can employ: direct pharmacological arterial dilatation, direct mechanical arterial dilatation. And when we talk about mechanical arterial dilatation, we're talking about our balloon angioplasty. Indirect arterial dilatation would be hypodynamic therapy, which I mentioned earlier, which we'll get into. And then other arms of it would be removal of potential vasospasmogenic agents. And in essence, what we're saying there is that we can do mechanical removal of the clot at the time of the surgery. Some centers, they actually can do subarachnoid irrigation with thrombolytic agents through cisternal catheters when you're clipping it, but that is if you're doing it within 48 hours, right? And of course, you want to protect the CNS from ischemic injury, and this is where nimodipine comes in handy. Improvements of the properties of the intravascular blood tends to be they've considered that it enhances the perfusion of ischemic zones, right? So it's generally accepted that it's generally accepted that a hematocrit of 40 or 30 to 35% is a good compromise because there's no optimal hematocrit that has been established per se. Statins is a little bit controversial in that, statins downregulate inflammation and upregulate your nitric oxide synthase, which helps to improve cerebral vasomotor reactivity and cerebral blood flow. But they've actually had a study called the STASH trial. And in that study, what they found was simvastatin was actually not useful. There was no benefit to simvastatin in these patients, right? But as for the last neurocritical care consensus in 2011, they actually still recommended using the other statins to continue patients who'd been on statins before, and that therapy in terms of starting new statins, we should really wait until we get the outcomes of, ongoing trials. So statins is a little bit of an experimental therapy there. So direct pharmacologic arterial dilatation, and there's several of these: smooth muscle relaxants, sympatholytics, intraarterial papaverine, and alpha ICAM inhibition, right? Calcium channel blockers, we know it's hard to find sometimes, or nimodipine, it's generally accepted for standard usage. And as mentioned before, it does not counteract vasospasms, but it's been associated with an improvement in neurological outcomes, right? Or endothelial receptor antagonists, again, clazosentan, we've spoken about this earlier in the previous lecture. Dantrolene, which is a ryanodine receptor blocker. This is actually interesting because what it does, right, is this is actually one of the few drugs that's been shown to prevent and reverse vasospasms because it mediates that intracellular calcium release from the sarcoplasmic reticulum, right? And this has been spoken about highly in several circles. Magnesium remains controversial in that there's a good bit of studies out there that have shown that magnesium sulfate is considered safe in treating subarachnoid hemorrhages, meaning the higher the serum magnesium concentration, the lower the probability of cerebral vasospasms. And it's interesting that there was a literature review that they did, and they found that up to 38% of patients would present with hypomagnesemia after an aneurysmal subarachnoid hemorrhage. So perhaps, this suggests that serum magnesium concentrations is closely related to cerebral vasospasms, right? So, like I said, there's literature both in support of it and against it, right? But that literature review was 558 studies that they looked at, and what they found was that basically there's room to evaluate for the prophylactic use of magnesium sulfate in the prognosis of SAH, right? Sympatholytics, and so it's been accepted for use, but it's not standard. Basically these again help with relaxing the smooth muscle in the blood vessels and reducing vascular tone to improve blood flow. Papaverine is a potent vasodilator, especially of the proximal, intermediate, and distal cerebral arteries, and can improve cerebral blood flow. Again, alpha ICAM inhibition is another experimental therapy that is accepted for use, but not available at all centers. And really what it is, it's an antibody to intracellular adhesion molecule has had some results with treating the vasospasms. I put these up here because it was really part of the formal treatment for it, but I've come across it using milrinone for cerebral vasospasms, right? So they actually had a Miller spasm control before and after study, and this was back in 2021, where what they did was propose this as a treatment option for cerebral vasospasms. And they actually had to prematurely discontinue the study, right? Because 29% of patients had um, poor tolerance to milrinone, meaning that they were becoming hypotensive and tachycardic. But in the patients that they did were able to evaluate, they found that they had lower rates of needing endovascular angioplasty, and you actually had a positive impact in terms of both neurological and radiological outcomes, right? So the preliminary findings were still encouraging, in terms of it was 94 patients that they did look at, and it really wasn't bad. And then there was a new one. Sorry, this was also 2021, where it was, but this one was a pool systematic review where again they use milrinone for treatment of delayed cerebral ischemia. And in this case, they checked 424 patients. And again, they saw a good response, that they saw that the angiographic response and clinical resolution was as high. Clinical resolution was as high as 88%. And remember, I'm telling you that the study, the cohort was 424 patients, right? And the angiographic response was 71%. But again, like I said, the side effects of milrinone was hypotension and in particular also hypokalemia. So you have to be very wary of it. But I wanted us to be aware of the fact that, this is out there and this is one of the new and upcoming things, right? And these are images that a DSC, a cerebral vasospasm. So you see that narrow long segment that I was telling you about on picture A, right? Um, right here, tapering. And then 5 days post-operatively, in this particular case, where they would have used, and this is the left MTA, they would have used milrinone, right, and nicardipine. You basically see that it's back. Yeah, you have good flow. You don't have that tapering, you don't have that narrowing, and that this patient was treated with intraarterial administration of milrinone and nicardipine, and you, like I said, you have really a resolved spasm, right? Vasodilation by angioplasty is another option. So, I mean, obviously, it's a catheter-directed balloon angioplasty of the vessels. Obviously, it's only going to be available in centers with interventional neuroradiologists. There's certain criteria for it. Failure of hypodynamic therapy, rupture aneurysm is repaired. Optimally, it's you get results, well, optimal results when you do it within 12 hours of symptoms, and it can be done immediately post-clipping for vasospasms that was observed pre-op. One of the big things you need to know is that if the patient had a recent cerebral infarction, aka a stroke, you cannot do this procedure. So these are the patients that you absolutely need to be sure that you don't see any, infarcts on CT or MRI when you do it before. Of course, you have risk, arterial occlusion, rupture, displacement of your aneurysmal clip. And one of the things with this to note is that, it's really only um feasible isn't the word, but kind of feasible in large cerebral vessels, meaning that your distal arteries tend not to be accessible. So you could only do it in your large cerebral vessels. But in cases that it's done, I mean, you see clinical improvement between 60 to 80% of cases. And this most studies have shown that it works, right? Agents use a chemical spasmolysis. So the next one that we would have said is arterial dilatation, right? And in essence, verapamil, nicardipine, we spoke of papaverine and nitroglycerin, right? The thing with this, right, is that you get the effect, but it's short-lived and it's less profound at the peak with angioplasty. And the problem is that you need to keep repeating it. So you need to do multiple arterial catheterizations. I mean, it does help to open up your vessels, especially if you're then going to place the balloon, or in vessels that you can't get to place the balloon in, right? But verapamil is the primary drug employed. But like I said, you tend to need to do serial arterial dilatations with this. Nicardipine, again, is a calcium channel blocker, so it acts on the smooth muscle and it restores vessels up to 60% of the normal diameter, right? And there's been retrospective studies showing solid evidence that, you have vasodilation and transient improvements in neurodeficits, right? Again, Papaverine, like we spoke about, it increases your angiographic vessel diameter and it decreases that prolonged cerebral circulation time, helps with your cerebral oxygenation. But again, it is of a transient nature and you need to do, multiple repeated infusions, right? Nitroglycerin is actually, I thought it was interesting in terms of not just in nitroglycerin, but now there's a trend of what they call nitro paste. So you can actually do it transdermally, and I thought that was really cool, honestly. So what they did, there was a small study where they used 5 patients with intracranial vasospasms, and this was also evaluated angiographically. And what they did is a non-invasive technique, is a paste, is a transdermal patch, and they actually found that all cases had moderate improvement in the degree of vasospasms, right? And I thought that was pretty neat. Um, but the point is, in terms of your practice guideline, because like you realize a lot of the things that I just mentioned, some of which are experimental, some of which are, smaller studies, but your practice guideline for management of cerebral vasospasms are gonna be, let's maintain euvolemia and normal circulating blood volume. We can induce hypertension unless blood pressure is elevated at baseline or precluded by cardiac stents, and these are level 1 evidence. And when we do all of that, then endovascular angioplasty and selective intraarterial vasodilator therapy is reasonable for patients not responding rapidly or to candidates for hypertensive therapy, right? And these are as per the American Heart and American Stroke Association guidelines. So what are some other measures we can do to prevent, this delayed or to care for patients with delayed cerebral ischemia? Your general care measures, right? So your neuro examinations, elevate your head of bed at 30 degrees, your regular stuff, run of the mill, TED stocking, strict ins and outs, your diagnostic measures, I would have made sure I said, you need to rule out any other cause of deficit. CT brain, make sure we don't have a hydrocephalus, make sure there's no new infarcts, make sure there's no rebleeds. We're working up the patient, ruling out anemia, sepsis, hypoxemia, hyponatremia, and of course you're using, repeat that transcranial Doppler once you have it available to you. You'll be able to detect your changes indicative of vasospasms. These are the patients, they have an arterial line for blood pressure monitoring, they have a pulmonary artery catheter for cardiac output, CPP, ICP monitors, and you want to ensure, and of course, these are the patients on nimodipine. You're keeping their oxygen where their PO2 is greater than 70. You want them to be euvolemic. These are the patients, the primary fluid you're going to give these patients is crystalloids, okay? Unless that blood hematocrit is less than 40, then you want to keep it around 40, like I told you, right? Once it's more than 40, you use crystalloids, in essence 10, right? Your HbF 10 or 8 to 10. If it's less than that, then you can consider using 5% albumin in terms of colloid for expansion. And these are the patients you check their electrolytes, their APG, their chest X-ray, their ECG, and you initiate hyperdynamic therapy that I've been, mentioning slowly every 2 minutes. Unless the blood pressure is elevated at baseline or if the patient has cardiac stents. So what is this therapy or what is this idea of, hyperdynamic therapy? All the treatments used to actually call it triple H therapy, hypovolemia, hypertension, and hemodilution. But now, we've gotten fancy and we've gotten a little smart and we say, you know what, in out with the old, in with the new, we're going to call it hemodynamic augmentation. And as a fancy way of saying, listen, you need to just maintain euvolemia and induced arterial hypertension, right? And you're using your fluids to maintain that euvolemia, right? You can administer pressors because you want to keep that pressure up as well so that we can have good cerebral blood flow, right? Yeah, you can administer that pressors to increase your systolic in 15% increments until neurological improvements, or if a maximum of systolic of 220, right? Because you also don't want them to stroke out. Agents include dopamine, levodopa, neoserine, and dobutamine, all right? And one of the nice things with phenylephrine or neosinephrine is that it does not exacerbate tachycardia, all right? So nice fancy term, hemodynamic augmentation. Be aware of the complications both intracranially and extracranially. Intracranially, of course, you can have your cerebral. It can exacerbate that cerebral edema and increase the ICP. You can have hemorrhagic infarctions in previous areas of ischemia. extracranial complications, especially, have to be aware of pulmonary edema. You cannot treat the patient in isolation. You can't just watch from the head up alone, right? You need to be aware of, and that's why our neuro patients are so critical in terms of the management, right? Pulmonary edema, you can see it in up to 17%. You can have MIs in up to 2% of cases, SVTs, complications of the catheter as well, you need to be aware of when we're doing this. So the next big complication we want to talk about is hydrocephalus, right? And like I would have mentioned, it affects up to 20 to 30% of patients with subarachnoid hemorrhages, right? And these patients, they develop this rise in intracranial pressure due to a number of factors, you know, the hemorrhage volume, the acute hydrocephalus hyperemia after the hemorrhage and or ischemia or just distal cerebral vasodilation, right? And there are several factors that are associated with it in terms of with an increased risk for hydrocephalus. The older age patients having an intraventricular hemorrhage itself, posterior circular aneurysms, treatment with antifibrinogen agents, and a low GCS on presentation, right? And the clinical presentation of hydrocephalus in this setting is progressive deterioration in level of consciousness accompanied by ventricular dilatation on head CT, and of course the ocular signs of elevated ICP. You can take it typically see your textbook symptoms, all right? Which is why I said it's important that in your patients with altered neurological status or confusion, you can't just say, well, these were spasms, right? You need to rule out all the other factors. So in the patient that you determine, you know, is okay, this is now hydrocephalus, the management ranges across the spectrum from CSF diversion, osmotic therapy and diuresis, decompressive craniectomy, to the patient may eventually be shunt-dependent hydrocephalus, right? So in essence, an immediate CSF diversion with an EVD or lumbar drain is indicated for patients who have deteriorating level of consciousness and evidence of elevated ICP and or hydrocephalus, right? I mean, of course, you can try if they don't have a ventriculostomy, you can do osmotic therapy and diuresis. And hyperventilation in these patients, you know, you tend to want to avoid it because it can precipitate vasospasms, right? Of course, in a setting, your third tier in terms of your management of your raised ICP, some cases demand a decompressive craniectomy. And of course, one of the things that they have in terms of the EVD is when to take it out. Some patients have it removed in hospital after clamping trial, and then they determine that, okay, it's fine to come out. Some would just leave it in for a week, right? But you have to recognize that some of these patients may actually end up needing a shunt post-EVD, right? And become shunt dependent. And predictors per se of developing shunt dependency would be acute hydrocephalus on presentation, a poor clinical grade at admission, vasospasm, intraventricular bleeding, as well as female sex. Okay. CSF diversion. So like I was saying, EVD placement, it's always indicated if it's deemed non-communicating and lumbar drain is an alternative, right? And controversy exists regarding the preferred mode of drainage. In that, I'm telling you, some experts recommend a rapid weaning of the EVD after you get that aneurysm secured. In essence, within 48 hours, you take it out once the patient's neurologically stable. Some schools of literature prefer to avoid weaning that EVD during the first week or longer and after the onset of a SAH, meaning they want to wait until that vasospasm has reached its peak within, you know, that 10 to 12 day window or 14-day window, and then decide that, well, okay, it's time to take it out. Because in essence, when you leave that EVD in, you're eliminating one cause right there. So you could know truly, well, it's not hydrocephalus, and you can determine, well, hey, okay, then this is vasospasm, or this is something else that is contributing to the patient's clinical presentation, right? Hyponatremia. Hyponatremia is a talk in itself. We're just going to touch briefly on how it's the relevance of it in this scenario, right? So the neurological effects, of hyponatremia may mimic delayed ischemic neurological deficits from vasospasm. And like I said, it follows aneurysmal subarachnoid in up to 30% of cases, right? So these patients, if they're hyponatremic, they actually have a 3 times incidence of delayed cerebral infarction than normonatremic patients and end up with longer hospital stays. What are some of the risk factors? Why do they develop it? If they have a history of diabetes, congestive heart failure, cirrhosis, adrenal insufficiency, if they've been using narcotics, NSAID, thiazides, all of these are risk factors towards them developing it as well, right? It's multifactorial and it can differ on a case-by-case basis. But the two big etiologies that we want to know is cerebral salt wasting and the syndrome of inappropriate antidiuretic hormone, right? So your baseline to know is that your cerebral salt wasting is the cause in the majority, is the cause of hyponatremia in the majority of aneurysmal subarachnoid patients, right? And that extracellular fluid volume is low in cerebral salt wasting. In syndrome of inappropriate antidiuretic hormone, it's normalized, elevated, and you have an increase in your ADH secondary. The thought process is that it's secondary, obviously, to hypovolemia, right? So cerebral salt wasting, it is caused by excessive secretion of natriuretic peptides that diminish that central sympathetic activity. It's characterized by volume depletion. I need you to know this. It's characterized by volume depletion, and then you have that release of antidiuretic hormone. So it can be treated with fluid administration using infusions of isotonic saline, but it may require infusions of hypertonic saline as well as fludrocortisone, okay? So in essence, what we're trying to do is to restore that euvolemia, and that will suppress the release of ADH, right? And then counteract your diuresis and your natriuresis that you're having with these conditions. SIADH, on the other hand, these patients are euvolemic. So in other settings now, your therapy of asymptomatic hyponatremia in SIADH usually consists of water restriction. But remember, these are not the patients, this subset of patients, the aneurysmal subarachnoids, these are not the patients that you want to fluid restrict. So in these cases, you're going to treat them with hypertonic saline because, and generally it's thought that, the subarachnoid hemorrhage increases the risk of your intravascular volume contraction and consequently your vasospasm-related ischemic injury. So to balance it, cerebral salt wasting and SIADH, it can be difficult to differentiate because I just said the laboratory findings are similar, meaning you have hyponatremia, a sodium less than 134, you have a low serum osmolality, less than 274, you have a high urine sodium, and you have a high urine osmolality. What is the distinguishing factor for you to know is the intravascular volume status in that patients with SIADH are euvolemic, right, or hypovolemic, while the patients with cerebral salt wasting are hypovolemic, okay? So your volume status becomes very important here. And like I said, because it's a little bit different in terms of managing, in this subset of population, they've actually had different protocol for the management of hyponatremia in these patients, where you can, obviously, if the sodium is less than 133 or you have a decrease of 6 mg in 24 to 48 hours, you administer sodium chloride tabs every 6 hours, you choose your sodium chloride infusion, and obviously you check your sodium. So this has been included in terms of thaw completion, right? Seizures, acute seizures, and we've spoken about acute seizures in the last talk, but we'll just review it nicely. This occurs in 8 to 15% of patients with subarachnoid hemorrhages, and these patients, in essence, what we do is that we treat them to prevent recurrence, generally only for a week, all right? And risk factors for it includes a thick clot, an intracerebral hemorrhage, delayed infarction, and they've seen a predisposition or correlation with aneurysms in the middle cerebral artery. Again, agents with favorable side effects are used, such as levetiracetam. And just to reiterate, we tend to avoid phenytoin because it's been associated with worse cognitive outcomes in these patients, right? So yeah, these are the patients that we treat for about a week and then we wean them. So to round up, the other complications I wanted to just touch on would be your cardiopulmonary complications, your prevention of ventilator-associated pneumonia and anemia. Because like I said, we're treating the holistic patient. These patients are already at so much they're at increased risk for mortality and morbidity. Aneurysmal subarachnoid hemorrhage, it's quite a toll, not just on the patient, but on the healthcare system as well. Pulmonary edema and cardiac arrhythmias tend to, complicate these cases, and up to a quarter of these patients can have these complications, and this is why it's important to look for ECG changes, to look for structural changes on echo, and the most frequent ECG abnormalities that you tend to see is ST segment depression, actually, and QT interval prolongation, right? And the point is that these ECG changes tend to be reflective of ischemic changes in the subendocardium of the left ventricle. And that in itself, having subendocardial ischemia, is an independent predictor of poor outcomes in patients with subarachnoid hemorrhages, and they must be managed aggressively because you don't want to go and clip these people aneurysm and think you do such a great job, and then MI kills them. Um, Also, some patients, and if you read hard enough, you would see something called Takotsubo cardiomyopathy, where you see that correlation with some patients developing a pattern of what is a transient apical left ventricular dysfunction. And it tends to mimic myocardial infarction, but there's no significant coronary artery disease. And they tend to see this as well in these subsets of patients. Of course, ventilator-associated pneumonia. This is why all our patients that are endotracheally tubed, make sure that they get ceftriaxone, because ceftriaxone is in fact thought and seen, and objective evidence shows that it decreases the risk of ventilator-associated pneumonia in these patients, most recently in a French study. Anemia, like I said, most studies suggest that anemia is associated with worse outcomes. And the goal has not been defined, as in the hemoglobin we're aiming for, but there's a recommended target by the Critical Care Society, again, in the last multidisciplinary consensus of 8 to 10 grams per deciliter, right? Neurogenic stress cardiomyopathy, just something that's out there, can peak anywhere between 2 days to 2 weeks. What they develop, in essence, is a myocardial hypokinesis, right? And when they develop that hypokinesis, their stroke volume, their cardiac output tends to be reduced. And then it can mimic MIs, but they're at a higher risk of hypotension, of actually having an MI. And so we need to be aware of that. The risk factors for it, again, higher Hunter Hess grade, female gender, smoking, and age, right? Arrhythmias and ECG changes, I told you already, we see in up to more than 50% of cases. And sometimes, these ECG abnormalities, they're indistinguishable from an acute MI. But you have these sympathetic activation that results in a hypercontraction of your cardiac myocytes and subsequent myocardial injury. Okay, so interventions in these cases, in terms of the arrhythmias and the ECG changes, you want to increase your cardiac output, because ultimately it comes back to your cerebral blood flow, right? And you need to maintain your cerebral perfusion pressure. So you can use milrinone or you can use dobutamine in these cases, particularly when they're hypotensive, all right? And finally, neurogenic pulmonary edema. It's defined that sudden increased ICP or hypothalamic injury can actually cause a sympathetic discharge, which causes more blood rush into your pulmonary circulation. You have elevated pulmonary capillary wedge pressure, increased permeability, and that surge, what it does, it increases your alveolar permeability, and they become very leaky, and then you end up with boggy and soggy lungs, and then these patients, they can't breathe, and their ABG looks like crap. And this is now where we're going to use measures such as positive pressure ventilation and lower levels of PEEP, because and obviously trying to keep down that ICP so we don't get that surge. Okay, there has been efficacy in using a dobutamine infusion in these patients, with obviously supplemented with our Lasix or furosemide, as we know, in terms of managing the lungs of these patients. So this is our final slide that really provides an image of what is deemed the care continuum of the patient with aneurysmal subarachnoid hemorrhage, right? And it's actually adapted from the 2023 guidelines for the management of aneurysmal subarachnoid hemorrhages, right? And I thought it's nice to sum up to talk on aneurysm subarachnoid, meaning, it's patient-centric care. There's phases of care, and there's that care continuum where you have that pre-hospital stage. They get into the emergency department. Then they're acutely hospitalized, where we either clip or coil. And then, of course, we have our post-acute care and our outpatient management of these patients, right? And what are the things that we're ultimately trying to do? prevent early brain injury, prevent delayed brain injury, and recovery of these patients. So you have acute resuscitation, you emergently diagnose them, you're trying to prevent rebleeding, you want to prevent hydrocephalus. So if you get your hydrocephalus, you want to treat it rather. You're managing your elevated ICP, you're managing your seizures, and you're doing all of this to do what? Prevent delayed cerebral ischemia, prevent that or fix that sodium dysregulation that you're going to have, as well as your systemic complications, glucose management, nutritional support, and ultimately being able to recover these patients and acute rehabilitation, managing seizures if they persist beyond that week that we treat them for, obviously not just that, but also monitoring and doing surveillance for aneurysms and screening for cognitive and mood disorders, because these are the patients that are also at risk of depression and anxiety, and given their quality of life and the life that they have post-operatively, or whatever would have happened during hospitalization. And in order to do all of that now, it's a shared decision making in terms of health equity and education, both to patient, family, as well as to ourselves and caregivers. And of course, trying to offer the best care that we can for these patients, right? So that brings me to the end of today's talk and the end of these references to talk on aneurysms.